Morning, everybody. This is a very basic course, so we do get references from a lot of pediatricians and other ophthalmologists for saying that some child has got squint, and then when we see, we find that actually there is no squint. So I'll first show some photo. Basically, this is I'll be speaking and showing just some photographs. I want you to take the mental picture of what you're seeing now, so that you get an idea of what to look for when you do the checkup of a squint. Now, the first thing that you have to do is do an alternate cover test. The video for that has unfortunately not got loaded. So, you just do an alternate cover test and check for eye movements. Now, having said that, first we'll discuss true versus pseudo squints. Now, let's come to a basic thing about the complaint. If there is a true squint, then the parents will say that the eyes are not appearing proper all the time. Okay. And in pseudo squints, they will say that the squint appears occasionally when he looks in some particular directions. Now, this second part is true for intermittent squints also. But the factor for that is that when you do the cover test, in pseudo squints there will be no movement. So even if it appears like a squint in some cases, when you do the cover test, there is no movement, and in true squint there will always be movement. Here I am assuming a bit that the vision is more or less equal in both the eyes. The potential visual acuity, it may be a refractive error plus or minus, whatever that is, but the potential visual acuity is more or less equal. It's a dense amblyopic eye, then it is not, the cover test sometimes doesn't work. But then you have to go by a photograph. And the reflex in a, this is reversed. In true squint, the reflex is eccentric, this is wrong. And in pseudo squint, the reflex is central. We'll show some photographs. Okay. So now you look here. This child appears to have a squint. The squint appears because you are seeing that this white, the sclera that is seen in these portions is different. But if you look very carefully, the face of the child is bit tilted. You see more of this ear and less of this ear. It means that the face is turned to the right a bit. This eye is a bit adducted. Now you look at the reflex of the corneal flash, the reflex of the flash on the cornea. You will find that both are absolutely symmetrical. So then you pinch the nose, keep the ears aligned, and then you find that the reflex is absolutely in the center and the sclera that is seen is a bit exposed. So this is the most common type of pseudo squint that is seen, a large epicanthal fold because of which the eyes appear esotropic. Similarly here, the eyes appear esotropic. Look at this sclera that is seen and on the temporal side, and once you pinch the nose you get that the corneal reflexes are in the center and the sclera is evident and the eyes are straight. In true squints, the reflex, as you can see here, is eccentric. This is a true squint. The flash reflex is off center. Here the reflex is here. In this eye it is here, and this eye it is here. And here in all the photographs you look very carefully, the head is straight. The head is straight. So when you take photographs for children to find out about squint or no squint, you have to first make sure that the face is straight, that the child is facing the camera. Both ears must be seen equally. If the both ears are seen equally, that means the face is straight, and then you can comment on the corneal reflex. These are photograph based, but you can do visual also, just by a small torchlight, a pen torch that we have. Don't take a very bright light, take a small pen torch, and the corneal reflex that you see from the pen torch is also good enough. These are cases of pseudo exo. You see that the palpebral aperture and this corneal reflexes are a little eccentric here. Now in this case, when you do the cover tests with the foils, there is no movement seen. Absolutely no movement seen. The reflexes are right in the center. These appearances are due to a abnormal palpebral aperture. So the key to distinguishing between True squint and false squint is the corneal reflex. That's very basic. I mean, you do a cover test and subsequently do for the prism bar, etc. That will come to later. But for a basic thing, do the corneal reflex, do a cover test. If there is no movement and if the corneal reflexes are in the center, it is a pseudo squint. If there is movement or if the corneal reflexes are not in the center, it's a true squint. That is just the basic take-home message. Again, these are now cases where the reflexes are eccentric. These are, the previous slide showed a lot of esotropes. These are some exotropes. Now we come to distinguishing between the incomitant and comitant. The topic was paralytic, but I am just extending it a bit to make it comitant. So comitant squint means the angle of squint is the same in all directions of gaze. And incomitant means the angle varies because one eye does not move very freely. Because one eye does not move very freely, that eye, the angle of squint between the two eyes changes. It varies from position to position. So, and this non-movement, the movement, restriction of movement may be due to paralysis of any muscle or may be restrictive like in Duane's. So classic examples would be sixth nerve versus Duane's where abduction is affected. So sixth nerve, the abduction is affected, and in Duane's type 1 also the abduction is restricted. The distinguishing feature in this would be that in restrictive strabismus, in the primary position, the angle of squint is much lesser than the amount of restriction. So suppose there is a sixth nerve palsy, total sixth nerve palsy, say it's a left sixth nerve palsy. What will happen is that the eye will be adducted more than 20 or 30 degrees and there will be a total restriction of abduction. But in Duane's type 1, even if there is total restriction of abduction, in the primary position the angle of squint will be hardly 10 degrees. So the angle of squint that is there is much lesser than the restriction, than the lack of movement. So if the lack of movement is -4 and the squint is just 5 degrees or 10 degrees, then the chances are that it is a mechanical restriction. And if the abduction restriction is -4 and the angle of squint is 20 and 30 degrees, that means it's paralytic. So that is one of the main distinguishing features between say Duane's type 1 and lateral rectus palsy, where the angle of squint in the primary position is much lesser than the restriction of abduction. So that's one thing. Now one more feature to be noted, that means by can say convention or whatever, the A and V patterns, because of the oblique muscle overactions, somehow have been classified under comitant, though ideally they should have come under incomitant because of the patterns, they are overactions of the superior or the inferior obliques. But because of convention, the A and the V patterns are classified as comitant. Somehow because what is mentioned is only the, by definitions from age-old times, the definitions of squint have been more or less based on the horizontal movements. We'll see some photographs. So this is a girl with A pattern exotropia. So she keeps her head, the chin down all the time, because in this case the eyes are more or less ortho. When they put chin down, you can see that there is a very big A pattern that she has. And when she looks to the left, this eye dips down, so superior oblique overaction in both the eyes. You can see that. So again, look at the corneal reflex. Here is more or less in the center, but here it's completely off. And post-operatively after that, this is fine. So this is now a case of Duane's, where what I was mentioning, keeps a slight head posture. Now this is the primary position. Now look at the amount of squint here. The amount of squint is negligible, but look at the lack of abduction. She just cannot move the left eye outwards. Very, very minimal movement is possible outwards, but the squint in the primary position is very minimal. You understand? So this was what I was meaning by the squint in the primary position is much lesser than the lack of movement. Now another feature here is in Duane's, is that the end point of treatment is correcting the head posture. So after the surgery, the head posture gets corrected, but the abduction is not changed. That you have to tell the patients that the kiss does not change. This is a case of Brown's, where there is restriction of gaze, and after surgery this goes up. This is a case where there is variable angle. I'll just take one more minute. This is variable angles of squint. So this is more or less a sort of a paralytic, where in different gazes there is different angles of squint. This eye is not moving much at all. The lids are also ptotic. This is a case of myasthenia, which after injection of neostigmine everything improved dramatically. Now this is a case where I would just like to show you, this is a case of pseudo squint. Now you'll see that this eye is completely lower than this eye. So this is a case of hypoglobus. Now look at the corneal reflex right in the center. Vision was equal. Eyes moved together in all directions. The patient's vision was 6/6. Binocular vision was Randot chart. He passed everything, but he did not get a driver's license because the RTO officers refused to believe that he had good vision. So I had to give a big certificate explaining all the tests that he has good binocular vision. So just keep this in mind, though, for pseudo squint or false squints versus true squints. Thank you.